Hello guys, this is Dr. Aman Setiya. So today we will discuss some expected topics and expected questions which are expected to come in your exam. Hemoglobin level, normal 12 to 17. Baby RBCs or baby hemoglobin, we call them reticulocytes. Reticulocytes, these are stained. These are stained by new methylene blue. So this will be a revision module. So I'll be moving little fast in this. The details discussion we will do in the separate videos. So if I say MCV, based on MCV means mean corpuscular volume, the normal values is 80 to 100 femtoliter. We divide anemia into three categories: microcytic, normocytic, macrocytic. If I say microcytic means values are less than 80, normocytic means values are 80 to 100, and macrocytic means values are more than 100. So if I just write it here, macrocytic means it is less than, macrocytic means value will be less than 80. This will be 80 to 100 and this will be more than 100. So let us see a few topics or few questions which they can ask. Transport form of ion is transferrin. The name of transporter is DMT1. DMT1 is divalent metallic transporter 1. Earliest parameter to decrease in iron deficiency is serum ferritin. Serum ferritin is reflecting the store form. So if you see, serum ferritin will decrease, store form will decrease, serum iron will also decrease. So always remember TIBC. TIBC is total iron binding capacity. TIBC is inversely proportional to serum ferritin. So remember this, my statement. If I say serum ferritin is inversely proportional to TIBC. So when ferritin will increase, TIBC will decrease. Red cell distribution width and free erythroprotoporphyrin level will increase. So these are the values, or these are the changes that we see in iron deficiency anemia. So these are MCQs suggestive of iron deficiency anemia. If I say a few more things, iron absorption will occur in duodenum. MCH will decrease, MCHC remain unchanged. Okay, so I'm having here an expected question, that is a fresh question, new question, possible question in your exam, that is Mendler index. Mendler index is ratio of your MCV and RBC count. So we calculate this ratio. If values are coming 13 or less than 13, I can say values are low. If values are low, so you can see the word L for low, thalassemia is having L. If values are increased, so I for increased, I for increased, I for iron. So values are increased means more than 13 in iron deficiency anemia. Okay, let us see features like patient will have fatigue, pica. Pica means patient will start eating non-nutritive things. There will be koilonychia means spoon-shaped nail. Pica means person start eating non-nutritive things like chalk, slate pencil, batti. There will be angular stomatitis. Patient can develop Plummer-Vinson syndrome. Another expected question from my side for you. Plummer-Vinson syndrome means patient will develop iron deficiency anemia. There will be esophageal webs. Generally we call them post-cricoid webs, and patient will have glossitis. So this is a triad, and this disorder is generally affecting females. So we see this disorder more in females. So the syndrome, we also call this Patterson-Brown-Kelly syndrome or Plummer-Vinson syndrome. So if I say oral supplement, we can give ferrous sulfate, fumarate, gluconate, or if I can say intravenously, we can give sucrose and carboxymaltose. One more is there, iron dextran, that we can give intramuscular. So these are the treatment options for iron deficiency anemia. Okay, let us move a few more things. X-linked ALA synthase deficiency. It can be due to lead poisoning, can be due to isoniazid toxicity. A part of myelodysplastic picture, you will see ring sideroblasts, papillary bodies, and high serum iron. So basically, patient will have iron overloaded state. These are MCQ suggestive of sideroblastic anemia. These are MCQs suggestive of sideroblastic anemia. So in the histopath, you will see papillary bodies. So this is from my side expected question in this attempt. And you can see ring sideroblasts. So this will be, these are two important points that you should know about sideroblastic anemia. Okay, Mendler index less than 13. There can be minor, intermediate, major. Serum iron will increase. If I say ferritin will increase. So TIBC will decrease. For screening we have a test. This test is called Nestroff test. And for confirmation, we can do HPLC. HPLC is high performance liquid chromatography. This is slightly better than hemoglobin electrophoresis. And here you can see in the histopath you will see target cell. So T4 target cells, T4 thalassemia. So these are MCQ suggestive of beta thalassemia. These are MCQs suggestive of beta thalassemia. Okay, moving ahead. Can be due to B12 deficiency, B9 deficiency due to hypothyroidism, alcohol consumption, liver disease, sometimes B6 and B1 deficiency. B6 is your pyridoxine, B1 is thymine. These are MCQs suggestive of macrocytic anemia. So out of these important two are B12 and B9. Okay, as you know, B12 absorption, B12 first will bind with R binders. Then pancreas or pancreatic protease, they will detach B12 from R binders. Intrinsic factor will take B12 to terminal ileum. So iron absorption, I told you, where in duodenum. If I say folic acid is predominantly absorbed in jejunum, and if I say B12 is absorbed in your terminal ileum. So deficiency of B12 is vegetarian diet. It can be due to pernicious anemia. Vegetarian diet they have asked in exam, so next time I am expecting this question. This will be your expected question. If I overlap medicine with microbiology, then remember Diphyllobatrum latum infection can be a cause. Congenital intrinsic factor deficiency, we call this Imerslund-Grisbeck syndrome. Or this also question came in exam, so they can ask again, small intestinal bacterial overgrowth syndrome. Homocysteine level will increase in both B12 as well as folic acid, but methylmalonic acid will increase only and only in B12 deficiency. Older tests, these days we don't perform, but still sometimes they ask MCQ. Schilling test is used for B12 deficiency. So these are MCQs suggestive of B12 deficiency anemia. B12 deficiency anemia. Okay, nutritional deficiency can be due to less dietary intake, or can be due to increased requirement as in pregnancy. Can be a part of malabsorption, but more important here you should remember is some drugs like methotrexate and anticonvulsant. If I name the anticonvulsant that they can ask you in exam is phenytoin. Very, very important, phenytoin. So you will see homocysteine level will be increased like in B12, but methylmalonic acid level will be normal. So these are your MCQs suggestive of folate deficiency. And remember, folate deficiency can cause neural tube defect. Folate deficiency can cause a neural tube defect in upcoming baby. So similarities, you know, both will have megaloblastic anemia, both MCV will be increased, both will have hypersegmented neutrophils. If I say the difference you should remember two difference. If I mark here two difference, first is B12 and B9. The first difference will be a clinical difference, that is B12 deficiency will have a neuro or CNS manifestation, neuropsychiatric manifestation in the patient itself. These are seen in B12 deficiency. If I say in folate deficiency, there will be no CNS manifestation. Now some of you are thinking, sir, you just told neural tube defect can be seen. So I am now telling you neural tube defect are seen in baby which is yet to come. I am talking about patient. So CNS manifestation can be a part in the patient. You will see there is no neurological impairment in case of folate. So this is one clinical difference that we see in practice, and one if I say laboratory difference, that will be MMA level. Methylmalonic acid level will increase. Here this level will be normal. MMA level will be normal. So this is how we differentiate one clinical and one lab parameter to differentiate B12 and B9 deficiency. Okay, worm type due to IgG can be idiopathic, seen in young female, associated with SLE and drugs like methyl-dopa. So what I want you to remember is worm type is IgG mediated and seen in young female. Worm type, so worm means hot, so how you can remember this? Hot means who is hot? Young females are hot, and there is more heat in Gujarat. So young females are hot and more heat in Gujarat. If I say cold type means M for Manali, M for mycoplasma. So Manali is in Himachal Pradesh, so you will see ice there, cold there. Cold type is seen where? In elderly. You can diagnose by comb test. In peripheral smear you will see spirocytes. These are MCQ suggestive of autoimmune hemolytic anemia. autoimmune hemolytic anemia. There can be autoimmune hemolytic anemia with a low platelet count. We call this Ivan syndrome. There can be Donner-Landsteiner antibody in paroxysmal cold hemoglobinuria. PIG-A gene, CD55, CD59. CD55 will code for DAF and CD59 for MIL. DAF is your decay accelerating factor and MIL is your membrane inhibitor of reactive lysis. There is activation of MAC. The test that we do is HAM test, but the best test these days we do is flow cytometry, and the drug that we use is eculizumab. So these are all MCQs of paroxysmal nocturnal hemoglobinuria, PNH. Paroxysmal nocturnal hemoglobinuria. Okay, a new question. Kasabet-Merit syndrome, there can be hemangioma with thrombocytopenia. Hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, antiphospholipid antibody syndrome, HELP syndrome, can be metallic or calcified object. In histopath, you will find helmet cells. Helmet cells, we also call them cystocytes. Helmet cells or cystocytes, these are nothing, these are your broken RBCs. These are broken fragment of RBCs. So where you will see these are all MCQ suggestive of MAHA, microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia. So I'm starting with hematology because in last attempt there were a lot of questions from hematology. Autosomal dominant type, mainly encorin followed by band 3. So most common is encorin. The test we do is Nestorf test, osmotic fragility test. We can do ectocytometry, eosin melamide test. Splenectomy is the treatment of choice. And in the peripheral smear, here also you will find spirocytes. So spirocytes, I told you at two places. So remember, there are two causes for spirocytes. One is AIHA, which is most common cause in adult, and second is your hereditary spirocytosis. So these are MCQ suggestive of hereditary spirocytosis. Okay, can be due to fava beans, sometime due to older anti-malarial. Older means quinine derivative. There will be decreased production of reduced glutathione. So this glutathione will no longer protect your RBCs. So RBCs are more prone to get oxidative stress. You can find in histopathology, RBCs, they will precipitate within, hemoglobin will precipitate within RBCs. You can see the pink discoloration for this venous supravital stain. This is what we call them Heinz body. We call this Heinz body. Now understand this, macrophages, splenic macrophages, they are like a possessive boyfriend. So they can't see anything abnormal attached to RBC. So if I say this is splenic macrophage, what they are sensing, they are seeing something is abnormal attached to RBC. So what they will do, they will take a bite, they will try to remove them. So if I draw this in front of you, this is your precipitated hemoglobin, we call them Heinz body. So macrophage, what they will do, they will take it out. They will take it out, so they will try to remove this, they will take a bite. So this left out cell, what we have now, what we call this, we call them as bite cells. Right? So left out cell is called bite cells. So this is, you can see in the peripheral smear, you can see bite cells. So you can see two MCQs that they ask again and again, Heinz bodies, bite cells, these are classically seen. So these are all MCQ suggestive of G6PD deficiency anemia. Glucose 6-phosphate dehydrogenase deficiency anemia. So if I say how we can confirm the diagnosis, the best test is enzyme test. So this is an X-linked recessive condition. So you will see mainly it's affecting boys. So females are just carrier of disease. Okay, you can see these cells. These cells we can see it look like a sickle. So we call them drepanocytes or sickle cells. We call them drepanocytes or sickle cells. So patient will have glutamate will replace by valine. So G4 glutamate, G4 gone. V4 valine, V4 welcome. So from today, valine spelling will start with V. Glutamate, valine. This is occurring at position 6. If I say sickle cell anemia, you will see the patient will have complaint like there will be dactylitis or there will be bone pain. If I write starting with this, there will be bone pain. There can be dactylitis, inflammation of finger. There will be risk of osteomyelitis. So just I am highlighting the important point. Patient can develop priapism. Osteomyelitis, generally the most common cause for osteomyelitis is Staph aureus, but here osteomyelitis is due to Salmonella. Priapism means sudden painful erection of penis. Sudden painful erection of penis. This can be seen in leukemias and sickle cell anemia. The patient can have chest pain, sudden onset chest pain. We call this acute chest syndrome. Acute chest syndrome. So sickle cell anemia, you will see this will provide protection against malaria. Okay, if I say CML, chronic myeloid leukemia, polycythemia vera, myelofibrosis, essential thrombocytosis. So these are 4 disorders which we call the myeloproliferative disorder, MPD. Out of this disorder, CML can occur due to BCR-ABL gene mutation, whereas these three occur due to JAK2 kinase mutation. So understand this. All BCR-ABL gene fusion will form a protein 210. This protein 210, this is due to a translocation called translocation 922. That is your Philadelphia chromosome. So these 4 are myeloproliferative disorder. There is pancytopenia. All cells are decreased with hypocellular marrow. Only fat cells you will see in bone marrow, because hematopoietic stem cells are gone. If I say the congenital cause is Fanconi's anemia, Schwarzman-Diamond syndrome, it can be idiopathic due to NSAIDs. These are MCQ suggestive of aplastic anemia. Aplastic anemia. These are MCQ suggestive of aplastic anemia. So in bone marrow aspiration, you will find dry tap. In bone marrow biopsy, you will find pancytopenia. Myeloblast 5 to 19%, there can be pancytopenia, can transform into AML. There can be 5q deletion, pseudo-peculiar Hewitt anomaly, Pound ball cells. Lenalidomide is the treatment. This is what we say, we call this myelodysplastic syndrome, MDS. Myelodysplastic syndrome. Okay, patient is having bone pain. There will be increased serum calcium. There will be M spike. Remember, M spike is a second spike after albumin. So in protein electrophoresis, you will see the longest spike. That longest spike denotes albumin. The second longest spike after albumin, generally we see this just in IgG area. It is mostly in IgG area, and sometimes you can see this where in IgA area. So remember, M spike is never IgM. M spike is mostly seen where? M spike is mostly seen where? It is seen in IgG area. There can be lytic bone lesion, especially in the skull and in the vertebra. In the skull, these lytic bone lesions are called as punched out lesions. Punched out lesions. There can be kidney failure, there will be anemia. In histopath, you will find Russell bodies, Dutcher bodies, Mott cells, flame cells. There will be Benz-Jones protein. Lenalidomide, bortezomib steroid combination we give. Older MCQ, we can give a drug called melphalan. So these are all MCQ suggestive of a plasma cell disorder. We call this multiple myeloma. Multiple myeloma. Oil rods, all-trans retinoic acid, arsenic trioxide, these are used in the treatment. So these are MCQs for your AML. So remember, in AML, most common type is M2. But most important type you will see, we call this M3. M3, we call this APML, acute promyelocytic leukemia. Acute promyelocytic leukemia, M3 is most important type. And if I say this APML or M3 type, this occurs due to RAR gene mutation. RAR is your retinoic acid receptor. And this RAR gene mutation is seen, so that's why we use all-trans retinoic acid as a treatment. Maximum oil rods, you will see this in M3 type. It can be due to B cell tumor or T cell tumor, B cell mass, C cell mass. If I say the combination regime we use is VA-PD regime, vincristine, L-asparginase, prednisolone, daunorubicin. This is most common leukemia overall and in children. So these are MCQs of your ALL. ALL is most common leukemia overall and in children. So vincristine is a toxic drug. It can lead to peripheral neuropathy and SIADH. L-asparginase can cause pancreatitis or pancreatic necrosis. Prednisolone is steroid which will have a lot of side effect and long-term use. Daunorubicin is cardiotoxic. It is cardiotoxic. Smudge cell if you see this leukemia, when these neoplastic cells they aggregate in lymph node, then we use the term SLL. SLL means small lymphoblastic lymphoma. There is dry and staging and associated with AIHA. So these are MCQs of CLL, chronic lymphoblastic leukemia. So when we use the term CLL, when it is a blood finding, if lymph nodal finding you will see, then in that case we use the term SLL, small lymphoblastic lymphoma. So if I say CLL, this is CLL. CLL can transform, this CLL sometimes can transform into CLL or SLL because it's a lymphoma component also here, so it can transform into diffuse large B cell lymphoma. So overall it's having a good prognosis. Overall it carry good prognosis, but when it convert into diffuse large B cell lymphoma, which is a non-Hodgkin lymphoma, this is a non-Hodgkin lymphoma, now it will carry a bad prognosis. This will have a bad prognosis. So initially you will see the patient having good prognosis. This transformation we call this Richter's transformation. We call this Richter's transformation, means a slow growing leukemia or lymphoma is converting into a high grade lymphoma. In histopath you will see classical Richtenberg cells, Hodgkin lymphoma. If I say most common type overall is your nodular sclerosis. Nodular sclerosis. If I say most common type in India, most common in India, it is mixed cellularity. Most common in India is mixed cellularity. If I say the type which will have best prognosis, we call them lymphocyte predominant. Lymphocyte predominant. On the other hand, if I say which will have worst prognosis, this is called as lymphocyte depleted. Lymphocyte depleted. Lymphocyte depleted means it is also called as lymphocyte poor. Okay, if I say sometime they ask a question like which type of special cells you will see, Richtenberg cells, RS cells or Richtenberg cells, these are giant cells which we see in almost all the Hodgkin lymphoma, but sometimes their shape is modified. If I say in nodular sclerosis, we will see lacunar cells. So remember, lacunar, nodular, lacunar, nodular. In lymphocyte depleted, you will see mummified Richtenberg cells. Mummified Richtenberg cells. Mummified, and in lymphocyte predominant, we see popcorn cells. We see popcorn cells. Popcorn cells are also, these are composed of lymphocyte and histiocyte, so we call them L and H cells. L and H cells. Okay, like Hodgkin, we have non-Hodgkin. So non-Hodgkin is slightly different from Hodgkin. So here we will have a B cell tumor and a T cell tumor. Non-Hodgkin can be a B cell tumor or a T cell tumor. So if I say, I'll give a mnemonic for this: Facebook do make hairy adult marvelous adorable. If I say Facebook do make hairy adult marvelous adorable. If I say face means follicular cell lymphoma. Follicular cell lymphoma. So generally in your exam they ask a question based on which is B cell, which is T cell. So remember, this is B cell tumor. B is your Burkitt lymphoma. It is one of the fastest growing human tumor. Burkitt's lymphoma. Most common type diagnosed and most severe type is your diffuse large B cell lymphoma. With time we have mantle cell lymphoma. Mantle cell lymphoma. With time there is marginal zone lymphoma. Marginal zone lymphoma. and with M we have maltoma. Hairy will be hairy cell leukemia. Hairy cell leukemia. Adult means adult T cell leukemia. Adult T cell leukemia. Marvelous is mycosis fungoides. Mycosis fungoides. Adorable means this is your anaplastic. Large T cell lymphoma. So what question they ask in exam is all are B cell tumor except, all are T cell tumor except. So how to remember this? I have given you the mnemonics. So sometimes they'll ask you some more questions. So just if I add on a few more things, is follicular cell lymphoma is translocation 14-18. F for 14, F for follicular, simple. Burkitt lymphoma, the translocation associated with this is translocation 8-14. Translocation 8-14. So this will be due to CMYC gene. So if you see B is the alphabet, only alphabet from B you can make 8. And after B, what we have after B, there is C. Mantle cell lymphoma is due to a translocation called 11-14. 11-14. So if I write here 11 and if I write here mantle, if you see carefully, here we have EL in this direction, there is EL in this direction. Something is better than nothing. Marginal zone lymphoma, remember it is the lymphoma associated with inflammation. Any inflammation like Sjogren syndrome, rheumatoid arthritis, right? So ulcerative colitis, there is risk of which lymphoma? Marginal, because margins are produced by those lymph nodes which are having repeated bout of inflammation. Hairy cell leukemia, if I say, hairy cell leukemia, here you will see these are positive for a dye called TRAP. TRAP is tartrate resistant acid phosphatase. And in the biopsy you will find here dry tap. In the aspiration you will find dry tap. Right? So we use drug to treat this is cladribine. Cladribine is the drug that we use. Adult T cell leukemia is due to human HTLV1 virus, human T cell leukemia virus 1. Mycosis fungoides, it is not a fungal infection. It is a T cell tumor. Initially it may look like a fungal infection, but later on it can modify, it can involve visceral organ. We call this Sézary syndrome. And last is your anaplastic large T cell lymphoma. Okay, if I say increased PT and PTT is seen where? Whenever there is liver failure. Liver failure, or I can say due to liver failure or vitamin K deficiency. You will see both PT and PTT, means prothrombin time and partial thromboplastic time, both will increase. For DIC, which some MCQs we are solving, if I say for DIC, test for DIC, what we have? We have fibrin degraded product, FDP. Abnormal Schilling test is for B12 deficiency. Abnormal Schilling test, antibiotic given for 5 days, then there is normalization. It means there was some bacterial overgrowth. We call this bacterial overgrowth syndrome. Bacterial overgrowth syndrome. HTLV1 causes adult T cell leukemia. Just now I told you. Adult T cell leukemia. MC value more than 100, that is your macrocytic anemia. Macrocytic or megaloblastic, remember the two important one, that is your B12 and your B9. B9 means your folate. Okay, poikilocytosis and anisocytosis. Poikilocytosis and anisocytosis, this is a feature of iron deficiency anemia. So these are seen in iron deficiency anemia. Transfusion related acute lung injury. So we call this TRALI. TRALI is due to massive blood transfusion. So there can be ARDS. Patient can develop ARDS, or there can be pulmonary edema. So this TRALI is generally, remember it is, the mechanism is HLA mediated, or we call this immune mechanism. A similar pathology you can see in the heart, we call this TACO. So massive blood transfusion can cause cardiogenic pulmonary edema. We call this transfusion associated circulatory overload, TACO. Or it is causing non-cardiogenic pulmonary edema, we call this ARDS or TRALI. Thalassemia, sickle cell anemia. So genetic overlap with medicine. If I say how they are inherited, answer is autosomal recessive. Low serum iron, low ferritin is seen in. So let us solve these questions one by one. So if I say we need to compare iron deficiency anemia, we need to compare anemia of chronic disease, and we need to compare sideroblastic anemia. So as you know, these all are microcytic anemia, so generally they ask a question on this. So the parameters that they give in exam is, you need to focus on serum iron, or they can ask you serum ferritin, or they can ask you TIBC. So to solve these questions, what is important, you should be knowing, first thing is serum ferritin is always inversely proportional to TIBC. Okay, first let me say iron deficiency anemia. Serum iron is reduced. Store forms, earliest to decrease is serum ferritin, and ferritin is inversely proportional to TIBC, so TIBC will increase. Simple. Understand this. Anemia of chronic disease, here all the iron is trapped with the help of interleukins and a protein hepcidin into stores. So store form is more. Store form is what? Ferritin. So store form is more. But this store form is more, but you cannot utilize this. Means it's like a lockdown. Lockdown for a showroom owner or a shopkeeper. There is a lot of stuff, but cannot sell it. So store form is more, and I told you ferritin is inversely proportional to TIBC. But you cannot utilize this, so serum iron is decreased. Sideroblastic anemia is iron overloaded state. Iron overloaded means body is having more iron in the serum, more iron where? In the ferritin. So if I say iron overload state means there is more ferritin, right? So TIBC, what will happen to TIBC? There will be decreased. TIBC will decrease. Iron overload means serum iron, if you check, serum iron can be more. So this is how we differentiate. To understand this, what question they ask in exam is, let's see the question, low serum iron and low ferritin. So where you will see, it is seen in iron deficiency anemia. If I say high serum iron and low ferritin, so you can see high serum iron and low ferritin, and high ferritin. If I say high serum iron and high ferritin, this will be your sideroblastic anemia. If I say low serum iron and high serum ferritin, this will be your anemia of chronic disease. Thrombocythemia or increase in thrombocyte, we can also use the term thrombocytosis. These are nothing, these are increased thrombocytes. Cystocytes are nothing, these are broken RBCs. So where you will see them? You will see them in MAHA. Sometimes they will not ask you MAHA, they will ask you causes of MAHA like DIC, HUS, TTP. HUS once asked in exam. Vitamin K is synthesized by your gut flora. Newborns, they don't have gut flora, they have sterile flora. So vitamin K deficiency is extremely common in newborn, otherwise it's very rare. Hemolytic anemia means hemolysis, hemoglobin converting into bilirubin. So it will convert into which stone? Which bilirubin stone. So remember, we have two type of stone. I am talking about gallstone, not kidney stone. If I say gallstone, the most common one are cholesterol gallstone, but the stone due to this pigment called bilirubin, we call them pigmented stone. Blood store temperature, if I say this is 2 to 6 degree. Sometimes they ask the average will be 4 degree. Myeloproliferative disorder, I told you the example. So there are many examples like CML, polycythemia vera, essential thrombocytosis and myelofibrosis. So CML was asked in exam. Post-splenectomy, which infections are common? So remember, the most common will be Streptococcus pneumoniae or pneumococcus, followed by H. influenza. Just I am writing this in a sequence. Followed by Neisseria. So these are three infections which are common. Drug of choice for CML, this will be your imatinib. Imatinib is tyrosine kinase inhibitor. This is the drug of choice for CML. Philadelphia chromosome is translocation between long arm of chromosome dash and dash. It is chromosome 922. Philadelphia chromosome is 922. Okay, so let's see question. All are seen in thalassemia major except. So thalassemia. So first I'll tell you MCV value. MCV values are less than 80. This anemia is called How to remember them? We call them microcytic anemia. We call them microcytic anemia. So microcytic anemia, mnemonic is Sheetal. So S is not sickle cell, S is sideroblastic. I is your iron deficiency anemia. If I say T will be thalassemia. This will be your anemia of chronic disease. And L is nothing, it is a variant of sideroblastics. It's a poisoning, we call them lead poisoning. So remember this Sheetal. So these are microcytic hypochromic anemia. So if I say thalassemia major is also called as Cooley's anemia, this is transfusion dependent. Yes, we need to give transfusion every 1 month or 1 to 3 months. So this is transfusion dependent. If I say macrocytic, except, so student don't see except in the question, it is not macrocytic, it is microcytic. Hepatomegaly can be seen, target cells can be seen. Priapism is seen where? It is seen in leukemias and it is seen in sickle cell anemia. Elective splenectomy is done in, so elective splenectomy we can do in any hemolytic anemia, but it is mostly done in case of hereditary spherocytosis. Here is a leukemia affect which cells? So simple answer, it's affecting your B cells. It's affecting your B cells. So let us revise some topics of GIT now. Esophageal cancer can occur due to some causes like Plummer-Wilson syndrome, Tylosis palmaris, achalasia cardia and Barrett esophagus. So understand this, these are pre-malignant condition for esophagus. Out of these, Barrett will convert only into adenocarcinoma. Barrett will convert only into adenocarcinoma. Lower GI bleed, if I say lower GI bleed, it can occur in two forms. It can be a fresh bleed. So fresh bleed, what we call this? We call this hematochezia. There can be fresh bleed, we call this hematochezia. Or if I can say there can be delayed bleed, this delayed bleed is called as melena. This will be delayed bleed. So most common cause of hematochezia, remember this is your hemorrhoids followed by diverticulitis. This is seen in adult. But if I talk about children, the most common cause of lower GI bleed is rectal polyp. For melena to occur, there is minimum 60 ml is needed. If I say most common cause of melena will be your peptic ulcer disease. Most common cause of melena is peptic ulcer disease. There can be many other causes, but most common, remember, peptic ulcer disease. Okay, you can see the image. We call this bird beak sign. Achalasia cardia. So if I say achalasia cardia, this occur, there is failure of ileus to relax. Lower esophageal sphincter will not relax. So what you will notice increase in tone of esophagus. So there will be no movement in esophagus. We call this aperistalsis. So I told you these three features. This is what we call this triad of achalasia cardia. If I say investigation of choice for achalasia cardia, it's a tone problem, means there is a problem in the pressure or tone. So how we diagnose by manometry. In barium swallow, you can see bird beak sign which is given in the image. If I say the treatment of choice, it's a surgical operation. We call this myotomy or Haller's myotomy. Diffuse esophageal spasm or esophageal angina. So this is how it look in barium swallow. So if I say this is also a tone problem, so how we diagnose? This is also diagnosed by manometry. It is also diagnosed by manometry, right? So if you see the appearance, we call this corkscrew appearance. You can see this appearance, we call this corkscrew appearance. GERD is a common problem. So remember, it is most common cause of non-cardiac chest pain. So overall, most common cause of chest pain will be your GERD. So basically there is acid reflux. So investigation of choice will be 24 hours pH monitoring. And if I say treatment of choice, we will give PPI, proton pump inhibitor. Barrett esophagus. So just I want to say this is Barrett esophagus. It is nothing. It is a metaplasia. There is metaplasia. So what happened here is squamous epithelia. Squamous epithelia is converting into intestinal type of columnar epithelia. gastrointestinal type of columnar epithelia. This is special because it will have goblet cells. It will have goblet cells. Okay, if I say gastritis, we can have type A, type B, type C gastritis. So I am focusing on type A and type B. If I say most common is type B, type A is relatively less common. So type B mainly affect your antrum and type A mainly affect your body. So how to remember this? Look at the screen. If I say rule of A to B, rule of A to B means A will involve body, B will involve antrum. A to B, B to A. If I say type B is most common, so cause is H. pylori. If I say type A, it is causing atrophy, so we also call this atrophic type. There will be anemia. Which anemia? It can cause pernicious anemia. And there will be achlorhydria. Achlorhydria means less HCl. Because there are some antibodies, this antibody will destroy your parietal cells. Mental disease. Right? So understand this. If I say mental disease, this is due to activation of TGF alpha. So we will see foveolar cell hyperplasia. Foveolar cell hyperplasia. You will see there will be enlargement of gastric fold. There will be enlargement of gastric fold. We call them cerebriform appearance. And how we manage, this is managed by a drug. If I say the drug of choice will be cetuximab. Cetuximab. Drug of choice will be cetuximab. Celiac sprue you already know. So it is due to an hypersensitivity to 4 cereals. Remember bro. Bro is barley, rye, oat and wheat. If I say the names of antibody, you will have to remember is anti-endomysial. So patient cannot digest these cereal. Anti-endomysial and anti-TTG. TTG is anti-tissue transglutaminase. Treatment is avoidance. You need to avoid these cereals. If I say inflammatory bowel disease, you can see Crohn disease and ulcerative colitis. So what question they ask in exam is, they ask an image-based question, that rose thorn appearance or string sign of contour, where you will see there will be cobblestone appearance. There will be cobblestone appearance of mucosa in Crohn disease. In ulcerative colitis, you will see toxic megacolon or loss of ostration. Loss of ostration. If I say pseudo-membranous colitis, so understand this is due to antibiotic overuse. So there is an infection with Clostridium difficile. Because of antibiotic overuse. If I say 3 antibiotic which you have to remember, which can cause this. So these are 3 antibiotic which we commonly prescribe in Indian scenario. If I say anywhere you go, Monosef or ceftriaxone is most commonly prescribed antibiotic. Patient is admitted with anything, give ceftriaxone, Monosef. So most common drug that can cause this. So understand this. What happens is this antibiotic they will damage your normal flora. So most common is ceftriaxone. If I say followed by the most potent one is clindamycin. If I say most common cause ceftriaxone, most potent is clindamycin. If I say oral cause is the antibiotic like what you guys are taking, what I am taking, what people are taking, amoxicillin. This is most common oral cause. Once you are admitted in hospital, generally you will see doctor will write Monosef, ceftriaxone. Empirical antibiotic of choice is Monosef or ceftriaxone. So how we manage this? To treat this, we have true drug available. So this is an anaerobic bacteria, Clostridium. So what we can do is we can treat this by giving vancomycin. So vancomycin could be expensive for few patients. So what we can do, we can also give metronidazole. So any one. So sometimes they ask a question like all except fashion, all are used, all can cause pseudo-membranous colitis except. So remember vancomycin, metronidazole, they will not cause, they are used in treatment. Malarious tear. Malarious is just a mucosal tear. It is just a mucosal tear. And Boreav is transmural. Transmural means it will involve all layer. So it is spontaneous esophageal rupture. So both can occur in alcoholics. So just a mucosal tear, we call this Malarious syndrome. Involving mucosa, submucosa, all layers, we call this Boreav syndrome. Is it clear? So understand this, when there is esophagus rupture, we call this esophageal rupture. Esophageal rupture. So you can see content of esophagus, they will come to mediastinum. So it can lead to pneumomediastinitis. It can cause pneumomediastinitis. So patient on palpation, auscultation, this patient will have crunching sound. This crunching sound will be looking like a lady is walking with a high-heeled boot in ice. We call this Haman sign. Or in other word, I can say Haman sign or crunching sound, or like you are eating kurkure or perk. Crunching sound, Haman sign. These are seen when there is rupture of esophagus. 3-year-old child with steatoria means fatty stool, weight loss, feature of malabsorption. How you will confirm? So best test to confirm any malabsorption is, remember, biopsy. Okay, next MCQ is nowadays they are asking overlap MCQ. Overlapping means integrating one subject with another. Correct about ulcerative colitis. It is not premalignant, false. It is a premalignant condition. It can convert into cancer. Incidence depend on smoking history. Yes, in ulcerative colitis, smoking is protective. So if you smoke more, incidence will be less. Increased risk in younger patient? No. Increased risk will be more in older patient. Directly related to disease duration? Yes, this is correct. So understand this, ulcerative colitis disease is directly related to disease duration. Initial treatment in Crohn's, remember these are steroids. Initially what we give steroids. Carcinoid tumor lead to increase in what in urine? So remember, carcinoid in urine, it is 5-hydroxyindole acetic acid in urine. If I say what is the parameter or what is the marker we use in blood, the marker that we use in blood for carcinoid is chromogranin. This is my list of expected question. Most common site of carcinoid, remember this is bronchus. If I say most common site of GIST, this will be stomach. Lady present with iron deficiency anemia and malabsorption. Iron deficiency anemia, malabsorption, most accurate test. Most accurate will be biopsy. But sometimes they will not give option biopsy, then you can find the antibodies like anti-TTG, anti-endomycin. Sensory ataxia, patchy loss of papilla. Ataxia is there, means neurological manifestation. Neurological manifestation are seen in which anemia? It is B12 deficiency. Cushing ulcers are seen in stomach due to stress or raised ICP. Any kind of intracranial stress, raised ICP, you will see Cushing ulcers. So S for stress. If I say on the other hand curling ulcer, curling ulcers are seen in burn. CURBUR, curling, burn. Male with epigastric pain radiating towards back. This is a case of pancreatitis. Pancreatitis. GERD, how we measure 24 hours pH monitoring. Silax Pro cereals, remember barley, rye, oat, wheat. Ulcerative colitis, not true about malignancy, there is metaplasia. So understand this question. Let's try to solve this question again. Unintegrated overlap MCQ. These type of things they are asking right now. They are focusing on patho relating with medicine, biochemistry integrating with medicine, right? Anatomy relating with surgery. So if I say ulcerative colitis not true about malignancy, so first you should understand this. If I say anaplasia is more dangerous, followed by dysplasia, followed by metaplasia. So most pre-malignant lesions is anaplasia followed by dysplasia, then metaplasia. So dysplasia, whether it is low grade or high grade, both are dangerous. Then metaplasia, so they are ruled out. Pleomorphism, Pleomorphism is seen in both anaplasia and dysplasia. If I say pleomorphism is +3, here pleomorphism is +2. That is the difference. So pleomorphism is feature of anaplasia and dysplasia. So understand this, not true is metaplasia. Clear? So this is how we solve the question. More dangerous are anaplasia and dysplasia, and pleomorphism feature of both. Drug of choice for enteric fever, it is ceftriaxone. If you want early healing, then we can add azithromycin. Enteric fever on fourth week. So if I say the weekly schedule, how we diagnose this, remember this mnemonic BASU. BASU means first week blood test, second week agglutination test, third week stool test, fourth week urine test. Aspirin can be used to, so here answer fourth week they are asking. Fourth week means this is fourth week will be urine test. Aspirin can be used to prevent which cancer? Colon cancer. Aspirin can be used to prevent colon cancer. So this is an image that they can ask you in exam. It is CBD dilatation in ERCP. Okay, so let us talk about some scores that we use in liver disorders. So MELD score is model for end stage liver disease. Model for end stage liver disease. So understand the component they ask in exam is CBI. CBI is creatinine, bilirubin, INR. So question that they ask in exam is all are part of MELD score except. If I say the pediatric version of MELD score is PELD score. So here we add few more things like bilirubin, INR, albumin, age of patient and nutrition status. Nazar index, this is indicated, this is like a score that we use for liver transplant in case of Wilson disease. So remember the component of Nazar index, this you can remember by a mnemonic SBI, SGOT, INR, bilirubin. Madris discriminant score, these are used in treatment for alcoholic liver disease. So we have only two things here, bilirubin and INR, BI. There are a few more scores that we use in alcoholic hepatitis like Madris discriminant score, Lilly score, Glasgow score. Child flu classification is for grading of cirrhosis. We have bilirubin, albumin, INR or PT or encephalopathy or any features of encephalopathy like asterixis. Then this is one tough thing that they ask in exam which is difficult for students. So what is this? This is called as CES. These are markers for hepatitis B. If I say these are markers for hepatitis B. These are markers for hepatitis B. So understand this. So this is like a one question that is coming in exam, and I have seen most of the students they skip this topic. So if I say how to solve this type of question, so SCES means first three will be sequence of antigen, next three will be sequence of antibody. So if I say this is your hepatitis B surface antigen, this will be your hepatitis B core antigen, and if I say this will be hepatitis B enveloped antigen. So first three will be sequence of antigen. If I say surface antigen is positive, it means this is the marker for entry of virus, viral entry. Core antigen is usually not detected in laboratory. It is not detected in laboratory. So not asked in MCQs. Even if it is asked, it will not make a difference. When it is not detected in laboratory, so not asked in MCQs. If I say enveloped antigen, if this is positive, it means the virus which entered your body, this virus is now dividing. It is now replicating. So this is a marker for virus replication. Virus replication means more viral load. More viral load means this is the period what we call this. This is now this infection is turning into infective. So this is marker of infectivity. Now if I say antibody, so antibody we write like this, anti-HBC antibody. This anti-HBC antibody can be of two types. So we can have IgM. IgM will be positive when infection is acute, or it can be IgG. IgG means when infection is chronic. So IgM is, if it is positive, IgM is positive means we call this acute. IgG is positive, we call this chronic. If I say anti-HBE antibody, if this is positive, It means virus which was dividing. HBe antigen was a marker for dividing or replication. Now we develop antibody against it. It means the virus is no longer dividing, means it is no longer infective. So it is non-infective means, or we can say end of infectivity. If I say, if you develop antibody for surface antigen, it means infection which was started from the top, now it is finished. So this is called end of infection, or I can say this is cured. So I'll give you few scenarios, so understand this. If I say the MCQ that they ask in exam is hepatitis B surface antigen positive. If I say HBe antigen positive and IgM anti-HBc antibody positive. So see, hepatitis B surface antigen positive means it's a marker of entry. HBe means infective. IgM means acute. So this is your acute infective hepatitis B. So understand this. If I say HBe antigen is negative, it will be non-infective. Or instead I can write anti-HBe antibody positive. Again it will be non-infective. If I replace the word IgM with IgG, it will convert into chronic. Right? Okay, if I say only anti-HBs antibody is positive. Only anti-HBs antibody is positive means virus have not entered, no entry. No entry means this is called vaccinated. And if I say only IgM anti-HBc antibody is positive, this is the status of your window period. So remember, IgM is too fast, it become positive before your surface antigen. We call this window period. So that understand this. Other MCQs are simple, they just confused between infective, non-infective. So remember, HBs antigen is entry, HBe is infective, anti-HBe is non-infective, IgM is acute, IgG is chronic. HBc antigen will not make a difference in MCQ. Okay, so see, this is alcoholic liver disease. We can have alcoholic hepatitis, alcoholic fatty liver, alcoholic cirrhosis. So most sensitive test will be SGOT, SGPT ratio. Most specific will be carbohydrate deficient transferrin. The prognostic index is MADRS. NAFLD. NAFLD is non-alcoholic fatty liver disease. Understand this. This NAFLD we use the term, but if this non-alcoholic fatty liver disease, if it is having some necrotic foci, you will see some necrosis, then we use the term NASH. The most common cause is obesity in adult and Ray's syndrome in children. So obesity is due to this junk food. So generally you can see half of the students who are watching this lecture, they may have this. So what are the symptoms? The most common symptom is no symptom or mild right upper quadrant pain. For diagnosis, we sometimes can use BARD score. If I say treatment is nothing, weight reduction. Okay, if I say chronic liver disease, CLD, can occur because of two main reasons. One is a virus, that is hepatitis B and hepatitis C, and second is alcoholic. These are two main reasons. So you will see patient can develop ascites. So puddle sign will be when it is more than 100 ml fluid, shifting dullness at 500 ml, or sometimes you can see massive ascites or tense ascites. Okay, this is expected question from my side. HRS. HRS is hepatorenal syndrome. So we have two variants, type 1 and type 2. If I say type 1 means there will be two parameters, that is serum creatinine. This will be doubled and GFR will be half of GFR and doubling of serum creatinine. This all will occur in less than 2 weeks. We call this type 1. If it is chronic progressive over many weeks and patient will have refractory ascites, we call this HRS or hepatorenal type 2. hepatorenal type 2. Okay, so understand this. What is the meaning of refractory ascites means? Refractory ascites means ascites which is not getting treated by using optimal dose of diuretics. It means you have tried the optimal dose of furosemide, that is Lasix, and you have tried the optimal dose of spironolactone. So understand this. What is the meaning of this refractory ascites means? You have given 160 mg of furosemide and 400 mg of spironolactone, means that is optimal dose. You don't have to remember the dose. Just remember optimal dose, highest possible dose you have tried, still patient is having ascites. We call this refractory ascites. So in this case, sometimes we use midodrine, octreotide, IV albumin. Primary biliary cirrhosis and primary sclerosing cholangitis. So just I want to draw a image in front of you to make you understand this. If I say this is your liver, so if I say we have the duct, these ducts are going inside the liver, we call them intrahepatic duct. Duct which are outside, we call them extrahepatic. Intra, extra. So when you see a problem, when you see a genuine problem, we see the problem in the intrahepatic duct. So if I say there is a problem where there is granular matter inflammation in intrahepatic duct, we call this primary biliary cirrhosis. And if you see the damage is mainly where? In extrahepatic duct. We call this primary sclerosing cholangitis. So there is some damage you can also see where? In intra. But maximum damage you will see outside. So understand this, both are autoimmune conditions, so there should be some antibodies. So I can say the name of antibody is anti-mitochondrial antibody. This disease is associated with ulcerative colitis, so antibody will be P-ANCA. So problem is inside. Problem is inside. So understand that the problem is inside, so there will be risk of cancer that is inside. So which cancer is inside? So there will be risk of HCC, hepatocellular carcinoma. Here the problem is outside, so there will be risk of cholangiocarcinoma. If I say both are problem with the liver and duct, so understand this, both disease, the first common symptom will be itching, but this itching is oftenly ignored. Morely, this is patient do not notice this itching, so there will be itching is first and most common symptom. If I say the drug of choice for both will be ursodeoxycholic acid. So this drug we can use in both the cases, UC-Bond, UD-Bond. This comes like 300 mg tablet. This is the treatment. But if I say the treatment of choice will be liver transplant, because this is like autoimmune condition. So treatment of choice for both scenario will be liver transplant. But liver transplant is not that easy. So understand this. If I say in this case I can't do anything, the problem is inside, but here I can try it for stenting. So if I put a stent over this, so there will be some relief. We call this stenting. So stenting you can try in this. So stenting you can try in case of primary sclerosing cholangitis. If I say in ERCP or MRCP, you will see this appearance. This appearance is called as pearls on string or beaded appearance in case of primary sclerosing cholangitis. Okay, Wilson disease. So it's a copper toxicity. So if I say the disorder is due to chromosome 13 defect, so let me count the spelling: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So I am removing this S. Count the number, this will be 13. The name of gene that is defective is ATP7B. ATP7A is for Menkes syndrome. So there is deficiency of ceruloplasmin. This is your copper transporting protein. So copper will accumulate in your liver. It will accumulate in your lenticular nucleus and brain. So we also call this hepatolenticular degeneration. If I say the drug of choice for Wilson disease, this will be zinc. Chelating agent we use, we have two chelating agents. These are D-penicillamine and triantine. And the new drug. So all these questions have been asked. So expected question will be the new drug that we have for this. The Harrison says a statement that this will be a possible new drug of choice in near future. So prognostic index, I told you we have Nazir prognostic index. So drug of choice, these all questions came in exam and there is a possibility they are expected to repeat again. Very important topic, Wilson disease. Hemochromatosis, like Wilson was copper toxicity, here we have iron toxicity. The most common symptom will be ulceropathy. There will be liver damage, so patient will develop liver cirrhosis. Iron accumulate in the heart, so it can lead to restrictive cardiomyopathy. Iron can accumulate in the skin, so there will be bronze discoloration of skin. There can be iron accumulation in pituitary, so there can be hypopituitarism. So understand this, here we use iron chelating agent like desferoxamine. Acromegaly, there is growth or increase in GH, increase in growth hormone in both the cases. But gigantism is something that is since birth. It is increase in growth hormone since birth, and this is increase in growth hormone after puberty. So more or less both are same disease. For screening we have IGF-1 test, confirmatory is OGTT, but investigation choice because most common cause will be a growth hormone secreting adenoma. So what we do a gadolinium based MRI. So we have growth hormone antagonist drug. This growth hormone antagonist is your pegvisomant. This is the drug of choice for acromegaly and gigantism. Okay, if I say diabetes insipidus, patient will have polyuria. Either it could be vasopressin deficiency, or there can be resistance. There is decreased urine osmolality, increased serum sodium. So we have two variants, that is central and nephrogenic. Central and nephrogenic. The test that we perform is water deprivation test. For nephrogenic, if I say, for nephrogenic we give thiazides. And for central we give desmopressin. Amiloride we use sometime when it is due to drug induced. Which drug? Due to lithium. The exact opposite of this will be SIADH. You will see there is more ADH or more vasopressin. There will be hyponatremia. There will be concentrated urine or scanty urine. The test we use is water loading test. So generally the question they ask is how to differentiate this. So understand this just simple way. If I say urine osmolality increase, plasma osmolality will decrease, urine sodium will increase, plasma sodium will decrease. So that's why plasma sodium will decrease. So what we see hyponatremia. So I want you to remember only SIADH. Reverse everything in case of diabetes insipidus. Just I want to add the treatment of choice. If I say, I told you here treatment like we have drug called desmopressin, or in case of nephrogenic, what we give? In case of nephrogenic, we give thiazide. And if I say the treatment of SIADH, we give Vaptans. Conivaptan, Tolvaptan. In older MCQ, sometimes they mention a word called demeclocycline. Okay, so sometimes they overlap medicine with physiology. So again, integrated question. So we have zona glomerulosa, fasciculata, reticularis. So these are the zones in the cortex. Go find rest. So what is released from glomerulosa? Understand this. It releases your mineralocorticoid. So just I am writing this. Mineralocorticoid means your aldosterone. Mineralocorticoid means your aldosterone. If I say the example of mineralocorticoid, this will be your aldosterone. Find means fasciculata, zona fasciculata. This will release your glucocorticoid. So go make good. Glucocorticoid means this will release your cortisol. Glucocorticoids or cortisol. So G4, glucocorticoid. Make good study. Go find rest. make good study. This will be secreting study for sex steroid. So understand this, these are three zones, zona glomerulosa, fasciculata, reticularis, and they release mineralocorticoid, glucocorticoid and sex steroid. Expected question, aldosterone is released from zona glomerulosa. Medulla will release your catecholamines like epinephrine, norepinephrine, dopamine. These are released from medulla. Cushing syndrome, you can see buffalo hump, moon-like face, moon face, buffalo hump. Right, there will be early boozing. This appearance we call this lemon on stick appearance. We call this lemon on stick appearance. Most common cause, if I say most common cause will be exogenous, means patient is taking steroid due to some reason. If I say what type of patient they take steroid, these are the patients which are having chronic inflammation like asthma or any autoimmune disorders like SLE. For any autoimmune cause, they are taking steroid for long term. Sometimes it can be due to endogenous cause, like there can be any adrenal tumor or there can be pituitary tumor, right? Antipituitary tumor or there can be adrenal tumor, or sometimes it can be ectopic. So for ectopic, remember it can be due to a tumor, that is your small cell lung cancer. Small cell lung cancer can also cause SIDH. We have dexamethasone suppression test to make a diagnosis. Slow tapering of steroid is recommended. Crohn syndrome, this is primary hyperaldosteronism. So you will see more aldosterone. More aldosterone means more salt and water retention. So more salt and water retention means there will be hypernatremia. There will be more salt retention, water retention, so there will be hypertension. There will be natriuresis, so there will be no edema. So this is special. There will be special point. There is no edema. When there is more aldosterone will cause more salt and water absorption, there will be loss of potassium and H positive ion. So loss of potassium means there will be hypokalemia and metabolic alkalosis. If I say Crohn syndrome, why it occur? It can occur due to a tumor or hyperplasia of your adrenal gland. Opposite of this will be Addison disease. We call this primary hypoaldosteronism. So it can occur due to autoimmune adrenalitis. So if I say this can occur also due to TB and HIV. So TB is a very common cause of damage to your, this is your primary hypoaldosteronism. Pheochromocytoma is the tumor that is released from your adrenal medulla. So basically it's a tumor of your enterochromaffin cell. These cells, if they are located somewhere else, we call the term paraganglioma. So remember, the patient will have three features, that is PhD. PhD means there will be palpitation. There will be palpitation. Patient can develop hypertension and there will be headaches. So with H I am having two things, and there can be diaphoresis. Diaphoresis. If I say to make a diagnosis, we can do a lot of things. So if I say how we make a diagnosis, just I want to mention here 24 hours urinary metanephrine. Urinary metanephrines. These are recommended. We can do some more tests for this. There are many tests, but if I want to go a little fast for your revision, we can do an MIBG scan. It is meta-idobenzoguanidine scan that we use for pheochromocytoma. How we manage? If I say two drugs we have available to treat this condition, generally we use these two drugs, that is phenoxybenzamine and phentolamine. Phenoxybenzamine and phentolamine. What do you think? All men are same, all men are not same, we have different men. So a girl was thinking all men are same, but all men are not same. When she joined medical school, she came to know she came around men 1, men 2A, men 2B, men 4. Men 2B sometime also called as men 3. This is one MCQ in your exam. I cannot predict here, but there will be one definite question. Man 1 3P, pituitary parathyroid pancreatic tumor. Man 2A will be, there will be, men 2A you will see there will be 1M and 2P. So there will be medullary carcinoma of thyroid, right? There will be pheochromocytoma and there will be parathyroid tumor. There will be medullary carcinoma of thyroid, 2M. There will be Marfanoid habitus, and there will be pheochromocytoma in men to be. Men 4 means there will be pituitary, parathyroid, adrenal, renal, and genitourinary. So remember this is, or I can say R for reproductive. PPARR. Pituitary, parathyroid, adrenal, renal, and reproductive tumor. This will be part of men 4 syndrome. These are other endocrine syndromes or other endocrine diseases which are associated with diabetes. So what you have to remember Cushing's. Cushing's is very important. Cushing can be associated with diabetes. Okay, patient is having abdominal obesity, triglyceride more, HDL levels are less, blood pressure is more, fasting blood sugar is more. So if I say these all features, so let me try to simplify this. Patient is having either diabetes or pre-diabetes, diabetes or pre-diabetes. If I say there is hypertension, stage 1, 2, or if I say the older classification, there is pre-hypertension. There is obesity, there will be lipids. Which lipids? If I say lipids, L for lipids. Which lipids? If I say triglyceride levels are more. If I say one more lipid, if I talk about one more lipid, this will be your HDL. So HDL levels are decreased. So in front of you, you can notice you have DHOL, DHOLL. If I say 3 or more features, if they are present, then we call this, it's a diagnosis of metabolic syndrome. Metabolic syndrome, also called as syndrome X. Metabolic syndrome or syndrome X. So easy now, metabolic syndrome. These are infections which are unique to diabetes. So you can see rhinocerebral mucormycosis and malignant otitis externa. These are seen, all are seen, but these are commonly as in MCQs. These are exclusively seen in diabetes. Okay, we have diabetic ketoacidosis versus coma. So if I say blood sugar values will be in this range, 400 to 600. If I say blood sugar values are more than 600, means sometimes your glucometer cannot show this value, it will show high. That is your coma. So this patient will have ketone bodies. If I say ketone bodies are present, here it will be absent. If I say DK, diabetic ketoacidosis, if you see ketoacidosis means pH will decrease. In this case, you will see pH will be normal. There is no acidosis. Because of ketone bodies, the patient will have fruity smell. Although we never and I in my practice I never smell a patient. So you will see fruity odor or fruity smell from mouth. Frankly speaking, I have never smelled such kind of smell. But sometimes they ask in exam, fruity smell. Because of ketone bodies, you will see fruity smell is present here. This is absent here. So understand this, if I say diabetic ketoacidosis is associated more with type 1. And coma cases are more associated with type 2. So just understand this. ONE1, if I fill in the blank, ketone. So ketone are more associated with type 1. So understand this, ketone bodies risk is more in type 1. But if I ask you most common cause of diabetic ketoacidosis, still answer will be type 2, because type 2 is way commoner than type 1. Type 2 is very common. There is more chance of DK in type 1, but most common cause of diabetic ketoacidosis or DK is still type 2. Okay, then we can see complication like retinopathy, nephropathy, neuropathy. There can be some macrovascular complication like risk of CAD. If I say there is 100% risk of peripheral vascular disease. Hypothyroidism. If I say hypothyroidism, most common cause will be Hashimoto's. Remember some drugs they ask in exam, lithium can cause, amiodarone can cause, and antithyroid drug overdose can cause. It can be due to dietary iodine deficiency, or sometimes it can be endemic in some areas like Himalayan belt in India. So these are common causes of hypothyroidism. So if I say how we manage, we give levothyroxine. So it's available in formulation of 25 microgram to 125 microgram. So depending on the weight we give to patient, so treatment is levothyroxine. Okay, 2 possible MCQs. If you give large amount of iodine, that can cause hyperthyroidism. We call this Jod-Basedow effect. Excess iodine can decrease thyroid hormone synthesis. We call this Wolff-Chaikoff effect. Right. So understand this. These are 2 effects that they ask in exam: Jod-Basedow and Wolff-Chaikoff. Graves' disease. If I say Graves' disease, toxic nodular goiter, struma ovary, these are causes of hyperthyroidism. Remember this, Graves is very, very important. Graves is very, very important. If I say the name of antibody that we find in Graves, it is your or I can use the term which antibody, this is what we call LATS, long acting thyroid stimulating antibody, or anti-TSI. There are many questions in exam from sugar values. Just I am writing the sugar values in front of you. If I say fasting blood sugar, it should be less than, okay, let me make the diagnosis of diabetes. If it is more than 125, if fasting values are more than 126, postprandial blood sugar is more than 200. If I say glycosylated hemoglobin HbA1c values is more than 6.5, right? And if I say random blood sugar, random is not a good test, but if random values are more than 200, along with this patient is having classical symptoms. Classical symptom of diabetes like polydipsia, polyphagia, polyuria, these are the classical symptoms. Then only we make a diagnosis of diabetes. So this is how we make a diagnosis of diabetes. One more test is available, that is serum fructosamine. Serum fructosamine will tell you diabetes status of past 2 to 3 weeks. Fulminant diabetes was encountered in Japan due to Coxsackie virus. With insulin, what will increase? So diabetic patient is having diabetic ketoacidosis. Ketoacidosis means ketone bodies are more, acidosis means pH is less. So when you give insulin, what will happen? pH will increase. Simple, easy question. All are associated with obesity. Prader-Willi, Lawrence-Boone-Biddle, Cohen syndrome, all are having obesity. Carcinoid will not have obesity. SIADH can be due to which tumor? So remember, it can be due to 2 tumors. It can be due to carcinoid. It can be due to a few more tumors. If I say SIADH can occur due to breast cancer, and SIADH can be due to small cell lung cancer. This is important. It can occur ectopically due to many cancer, but remember at least these 3: small cell lung cancer, carcinoid and breast cancer. Okay, you can see this overhanging edges with sclerotic margins. This sign is called as Martel sign. Martel sign, or we call this G sign. These are your needle shaped crystals. So in gout you will see tophi, males are commonly affected. Serum uric acid may be normal. In acute gout, if I say the drug of choice is NSAIDs. In chronic gout, the drug of choice will be allopurinol. In acute gout, we can also use colchicine. Similarly, in chronic gout, allopurinol is the main drug. But sometimes there is indication like allopurinol if we avoid in patient of CKD or acute kidney injury. In that case, renal safety is more with febuxostat. Okay, so sometimes students get confused, like steroid also we can give in acute gout. So remember again A to C rule. A for acute gout, in acute we use colchicine, C for chronic we use allopurinol. So A to C, C to A. Newer drugs, if I say new drugs which are available, that is your rasburicase. Newer drug that we have is rasburicase. Rasburicase, and one more is there, pegloticase. Saturnian gout is due to lead poisoning. It is due to lactoxity. Charcot joint, you can see Charcot joint, these are pain-led destruction joint. Most common cause will be diabetes. So remember, these are neuropathic joint. Most common cause will be diabetes. Chromosome 12, tall height due to fibrin mutation, autosomal dominant condition, pactus carinatum. There is risk of mitral valve prolapse. These are all are MCQ suggestive of Marfan syndrome. If I say diagnostic criteria is called as Gent's criteria. Bouchard's nodes, these are seen in the proximal joint or proximal joints. We see Bouchard's nodes. Haberden are seen in distal joint or DIP. In PIP you will see Bouchard's nodes. Haberden you will see in DIP. Right? These are features of osteoarthritis. Osteoporosis, if I say the drug of choice will be bisphosphonates. In postmenopausal female we can add something else, we can add hormone replacement therapy. In case of refractory case, we give denosumab. This is monoclonal antibody. So how we make a diagnosis is by T-score or Z-score. These values are important because they ask orthopedics overlap with medicine. -1 or more, it's normal. 2.5 or below, we call this osteoporosis. Most common organ affected is lungs, followed by lymph nodes. You will see 3 bodies, that is Schaumann bodies. You will see 3 bodies, that is Schaumann bodies. Asteroid body, residual body. There will be non-cascading granuloma. There will be increase in level of ACE and there will be increase in calcium. There will be increase in calcium. Okay, if I say the patient will have skin rash, the skin rash is called as lupus pernio. There will be Guilhem scan. In this Guilhem scan we will see panda sign. Kivim test is no longer used. In bronchoalveolar lavage you will see CD4 is to CD8 ratio. This will be increased. This will be like 4:1, 5:1, 6:1. And you can see Garland sign, that will be involvement of hilar and paratracheal lymph nodes. So these are MCQ suggestive of sarcoidosis. Okay, for vasculitis we have a Chappell classification. So we divide vasculitis into large vessel vasculitis, medium vessel vasculitis and small vessel vasculitis. Large vessel, medium vessel, small vessel. If I say large vessel, remember 2T. 2T means temporal arteritis and Takayasu arteritis. Temporal and Takayasu arteritis. Medium, remember a mnemonic, Pandits. This is your Pandits. Pandit is having a Kawasaki bike. Pandit's Kawasaki bike. So if I say Pandit means first 3 alphabet Pan. Kawasaki means Kawasaki disease. B for bike, B for Berger's disease. Berger's disease. Small vessel vasculitis, if I say, we have diseases like Hanoch-Schönlein purpura, microscopic polyangiitis, Churg-Strauss syndrome, and Wegener's granulomatosis. So this is the classification, we call this Chappell-Hill classification. RBC cast are seen in nephritic syndrome. WBC cast, these are seen in pyelonephritis. Hyaline cast, these are normal. Sometimes they can form Tom-Hirschfeld protein. So sometimes they can form Tom-Hirschfeld protein. If I say broad granular cast or waxy cast, these are seen in CKD. Muddy brown cast, these are seen in ATN, acute tubular necrosis. Okay, DTPAP for perfusion, DMSAM for morphology. So understand this, perfusion means any functional defect. Perfusion means any functional defect. We use DTPA scan. If I say morphology means any anatomy defect or anatomical defect, we use DMSA scan. For kidney function, if I say for GFR, we have some tests like creatinine clearance, inulin clearance. Then there is Cockcroft-Gault formula. We have MDRD. MDRD is modification of diet in renal disease. And the best one, the latest one, that is the best one. This will be again an expected question, that is Cystatin-C method. Cystatin-C method. For tubular function, we do water deprivation test, and for renal plasma flow, we have para-aminohippuric acid. So these are the methods for GFR estimation. So just I am putting this slide up. These are the methods which we use for GFR estimation. Okay, if I say dialysis, so in dialysis we have two variant of dialysis, like we have hemodialysis and peritoneal dialysis. We make a fistula, so generally the purpose of this fistula will be, there will be arterialization of vein. There will be arterialization of vein. So when we create a fistula, with the same fistula we can use the dialysis for many weeks. If I say the recommended dialysis is thrice per week. The recommended dialysis is thrice per week. So generally dialysis we do when patient is having CKD, or if I say patient is having AKI. So in AKI, when patient is having hyperkalemia, in last resort, hyperkalemia, or patient is having worsening of symptom, very high serum creatinine or urea, we can perform dialysis. If I say what else about dialysis, they can ask you, in dialysis there is risk of A beta 2 type of amyloidosis, A beta 2M type of amyloidosis, A beta 2M type of amyloidosis with dialysis. Pyelonephritis. If I say pyelonephritis, the most common cause will be E. coli, followed by Klebsiella, followed by Proteus. So you will see WBC cast, and in the urine routine microscopy you will find some pus cells. In diabetes, the first sign in diabetes is diabetic nephropathy. That is first sign of diabetic nephropathy. This will be your microalbuminuria. In this case, when you see microalbuminuria, we have ACE inhibitors which can prevent this microalbuminuria, or which can prevent further damage. If I say most common finding will be diffuse glomerulosclerosis. If I say most specific finding will be nodular. These nodules are called as Kimmel-Steele-Wilson nodule. These nodules are called as Kimmel-Steele-Wilson nodule. Kimmel-Steele-Wilson nodule. Okay, then discuss some topics of neurology. If I say headache, so I am talking about primary headache only. If I say most common primary headache will be tension headache. Then we have second type of headache, that will be your migraine. I am talking about primary headache. If I say third will be your cluster headache. So if I can say tension headache is most common, second most common is migraine, third is common is cluster. If I say in tension headache, in acute attack, the drug of choice will be NSAIDs. So during attack, what we give NSAIDs. In case of prophylaxis, we give tricyclic antidepressant, or we can say, understand this, if there are less than 15 episodes in a month, we call this acute. In that case, we give NSAIDs. If more than 15 episodes, we call this chronic. So understand this, in case of chronic, what we give? In case of chronic, we give TCA. Okay, if I say migraines, the drug of choice for migraines are triptans. Again, these are preferred in attack. If I say for prophylaxis, what we prefer to give beta blocker, non-selective beta blocker, that is propranolol. This is preferred in prophylaxis. They can also give calcium channel blocker and TCAs, but most preferred is beta blocker. If I say cluster headache, during attack, we give oxygen at the rate of 10 to 12 liter. So drug of choice during attack is oxygen. If I say for prophylaxis, what we prefer to give verapamil. Verapamil is preferred for prophylaxis. So these are three common type of primary headache. Guillain-Barré syndrome, GBS. So if I say GBS, remember the most common trigger will be Campylobacter. So we have GBS based on symptom. We divide into acute and chronic. If I say acute, the most common form is AIDP. We have acute inflammatory demyelinating polyneuropathy, Aman, Amson, acute motor axonal neuropathy, acute motor sensory axonal neuropathy, and the fourth is called Miller-Fisher syndrome. The chronic form is called as CIDP. So understand this. In acute form, how we manage? In acute form, we manage this by IV immunoglobulin. In chronic cases, we give steroid. Most common acute form is AIDP, but in exam they ask question on triad of Miller-Fisher syndrome. So this you can remember by AO. AO means patient will have ataxia, areflexia, and ophthalmoplegia. Ataxia, areflexia, and ophthalmoplegia. This is a triad of Miller-Fisher syndrome. Again, a very important topic. So few points. If I say myasthenia gravis, there will be ptosis. Patient will have ptosis. If I say the facial appearance, this face of patient, there will be vertical opening of mouth. We call this snarling face. For diagnosis, we can do ice pack test. It is a simple bedside test. Ice pack test means you will apply ice and patient ptosis will improve. On application of ice, ptosis will improve. Then we can give patient injection of adrophonium. We call this tensilon test. So we give 2 mg followed by 4 mg, 4 mg, 2, 4, 4. Means total 10 mg we can give adrophonium and see the patient symptoms improve or not. Then we can do single fiber electromyography. And we can do repetitive neurostimulation. In this we will find decremental response. Myasthenia is associated with thymoma. So remember, thymectomy is recommended in all patients. The differential for myasthenia will be Lambert-Eaton myasthenia syndrome. So understand this. Here you will see anti-PQ type of calcium channel antibody. In myasthenia you will see anti-acetylcholine receptor antibody. Here you will see incremental response. And if I say in Lambert-Eaton, what is important is you will notice this is associated with small cell lung cancer. So there can be association with small cell lung cancer. Duchenne muscular dystrophy, Baker muscular dystrophy. So understand this. These are two diseases. These are due to a defect in dystrophin. So understand this. Dystrophin is very important protein for your muscle. So D for Duchenne, D for don't make dystrophin. B for Baker, B for bad quality dystrophin. So here there is no dystrophin. There is bad quality. So understand this. Both are almost same disease. Here the quality is bad. And here there is no dystrophin at all. So always remember, be happy with what you have. Something is always better than nothing. So I can say Baker is milder variant and Duchenne is severe variant. So both are very commonly seen. Both are not commonly seen, but both are severely affecting the babies. So these children will be wheelchair bound, and generally the diaphragm is a muscle, so cause of death will be a diaphragmatic failure. So these babies, understand this, when they want to stand up, so they will use all four hand or a chair or So anything what is near to them to stand. They will crawl, then they'll stand. This sign is called as Gowers sign. Epilepsy. If I say in epilepsy, the question they ask in exam based on management, if I say in most seizures, in most epilepsy, we give valproate. In most epilepsy, we give valproate. If I say in status epilepticus, when patient is having repeated seizures, in that case, if I say the drug of choice is lorazepam. In case of febrile seizures, we give diazepam plus paracetamol. We can also give intranasal midazolam. If I say seizures in case of pregnancy, okay, do not confuse this with eclampsia. Eclampsia is pregnancy-induced seizures. So, pregnancy seizures means patient is already pregnant, already a case of epilepsy or seizure disorder, and she became pregnant. Eclampsia is something different. Eclampsia is seizure due to pregnancy. So understand this. In eclampsia, what we do is there is MgSO4 is given, magnesium sulfate. But in pregnancy-induced epilepsy, remember you should continue with the same treatment. That is called CST. CST means continue same treatment. Otherwise, there are 4 drugs which are considered safe in pregnancy: levetiracetam, lamotrigine, phenobarbital, and carbamazepine. So these we prefer from these 4 lists. I repeat: levetiracetam, lamotrigine, phenobarbital, and carbamazepine. Multiple sclerosis, you will see patient will have sensory complaint. There will be motor complaint. There will be sensory complaint, motor complaint. There will be optic neuritis. The patient will have, when you flex the neck, there will be electric current like sensation. We call this Lermite sign. You will take the patient to a hot shower or a sauna bath. Patient will have worsening of symptom. We call this Uthoff's phenomena. And if I say for management, for treatment, we give steroids, and we can also use interferon beta. Alzheimer's disease, remember, this is also called as irreversible cortical senile dementia. The protein that is accumulated is tau protein. This tau protein will form neurofibrillary tangles. And if I say this neurofibrillary tangles, more the tangles, more severe is the disease. In Alzheimer's disease, you will notice the patient is having progressive memory loss over slow duration. There is dementia, means memory loss, amnesia plus some cognitive defects. So what we say is, in Alzheimer's disease, you will see neurofibrillary tangles. There will be A beta type of amyloid. And if I say the most preferred drug, what we have is, we have donepezil followed by rivastigmine. We can also use galantamine, memantine. Tacrins are no longer considered because of hepatotoxicity. Parkinson disease. So you will see the patient will develop tremors. There will be rigidity. There will be bradykinesia or hypokinesia. So if I say, because of this rigid posture, sometimes they will not give the word rigidity, they can use the word freezing. And because of this kind of attitude, they will have frequent falls. So they ask a question in exam is, all are feature of Parkinson except. If I say the 4, these are the triad. If I say the 4th feature will be postural instability. So you can see the patient will have mask-like face, expressionless face. There will be reduced arm swinging, stooped posture. caudate nucleus is damaged, you will see chorea. Chorea is involuntary, or you can say involuntary purposeless movement. Putamen. So C for caudate, C for chorea. So remember, gap means globus pallidus, putamen. In globus pallidus and putamen defect, you will see athetosis. So remember this gap. Thalamus bellismus. So these are defect of movement or motor defects. Lower motor neuron lesions, you will see flaccidity. So just I am marking something. Flaccidity, L for flaccidity is having L. Low reflex. So I am writing this low reflex. Fasciculation. Right? Low tone. One more, if I say low tone or hypotonia. So just remember this one. These are the feature of lower motor neuron lesion disease. If I say spasticity, brisk or exaggerated reflex, or hyperreflexia and hypertonia, increased tone you will see where? In upper motor neuron lesion. Okay, then different type of gaits. So nobody will ask you hysterical gait. Waddling gait is due to bilateral dislocation of hip. Lurching is due to unilateral dislocation of hip. Magnetic gait, these are important, and fascinating gait, this is baby step movement. This is seen in Parkinson. Normal tendon reflex with muscle weakness is seen in myasthenia. Reversible dementia, remember all the vitamin deficiency, hormonal deficiency like hypothyroidism. All these vitamin deficiency, these are reversible. So one example I am writing is this MCQ came in exam, SACD. SACD is severe acute combined degeneration of spinal cord, that is due to vitamin B12 deficiency. So when you give B12, it may reverse. Alzheimer, Parkinson, neurodegenerative disease, Huntington, Lewy body, Pick's disease, these are neurodegenerative disease, these are always irreversible. Extensor plantar reflex on pitching gastrocnemial muscles, we call this Gordon reflex. Horner syndrome you can remember by a mnemonic Punjabi meal. Punjabi meal is ptosis, meiosis, anhydrosis. Ptosis, meiosis, anhydrosis, loss of ciliospinal reflex. If I say ptosis, meiosis, anophthalmos, anhydrosis means loss of sweating, and loss of ciliospinal reflex. Loss of ciliospinal reflex. Inability to recognize face is called prosopagnosia. Prosopagnosia. Complete transaction of spinal cord, understand this, there will be loss of bladder or all senses below the level of lesion. If you see half transaction, that is called Brown-Séquard cord syndrome. There will be ipsilateral loss of tactile vibration and position, and contralateral loss of pain and temperature. Pannulogenic lesion of cerebellum. Ataxia, reflexia, ophthalmoplegia, where you will see Miller-Fisher. It is seen in Miller-Fisher syndrome. Semi-purposeless, non-repetitive, dynamic distributed movement, these are called as chorea. These are chorea. CSF glucose, understand this. CSF glucose is 2/3 of blood glucose. 2/3 of blood glucose, if I say, this will be 66.66%. 2/3 of blood glucose, so this is almost equal to 60 to 80%. Ipsilateral Babinski and ipsilateral membranes, we call this Kerohan-Voltman sign. Drug of choice for listeria, ampicillin. SSP is a complication of measles. Okay, normally cells are increased, proteins are increased. If you see cells are normal but proteins are increased, we call this albuminocytological dissociation. Albuminocytological dissociation. Albuminocytological dissociation is seen in GBS, Guillain-Barré syndrome. Okay, then there is always a question of Glasgow coma scale. Very, very important topic, Glasgow coma scales. Every time they ask a question in this. So, point is, student, don't study this. Okay, first understand this. Glasgow coma scale, GCS, we have 3 parameters, eye, verbal, motor. So first remember, there is no 0 here. Minimum score is 1. So remember first EVM and 456. 456. EVM 456. So if I say minimum is 1, so 1, 1, 1 means minimum will be 3. If I say maximum 6 plus 4, 10, 10 plus 5, 15. So maximum will be 15. So minimum score will be 3. maximum will be 15. So how to understand this each component, understand this. We'll study in a different way. Like you have seen in books 1, 2, 3, 4, we'll study like 4, 3, 2, 1. So if I say, you'll ask the patient, open your eyes, he is opening, we give a score of 4. He's not opening, you are shouting him, then he's opening the eyes, score of 3. You are pinching or pressing or giving some pain, then he's opening, we give a score of 2. You tried everything, he is not opening, we give a score of 1. So I is simple. Spontaneously, with sound. So you can remember this by a simple mnemonic, ESPN, sports channel. I opening spontaneously, sound, P for pain, N for no response. Okay, let's see the verbal response. Patient is oriented, we give a score of 5. Confused, score of 4. He is saying inappropriate word, we give a score of 3. You are asking something, patient is just moaning with sounds like ah, e. This type of sounds the patient is making, incomprehensive sounds like ah, e, then we give a score of 2. No response, we give a score of 1. So how we remember this? We can remember with our country win. 5, 4, 3, 2, 1. Okay, let's see how to remember the motor component. You ask the patient to elevate your right arm, patient is elevating, we give a score of 6. He is localizing to pain, we give a score of 5. Withdrawing to pain, 4. Flexion attitude, we give a score of 3. Abnormal extension, we give a score of 2. And no response, we give a score of 1. So understand this flexion attitude, we call this, we give it a name, we call this decorticate posture. Decorticate posture means patient is having a flexion attitude, like this attitude in the bed. Abnormal extension, which is more dangerous, we call this decerebrate posture. So how you can remember this? You can remember by a mnemonic, can't live without fan, F-A-N, simple. This is one short question in exam. So try to study this very carefully. Okay, some cardiology review, then we will finish the discussion. So see, if I say Down syndrome, the most common cardiac defect is endocardial cushion defect, but in exam generally they ask question on VSD. In DGR syndrome you will see tetralogy of Fallot, Friedreich's ataxia, HOCM, Cartagena, dextrocardia, Marfan you will see mitral valve prolapse. Then understand there are some questions that they ask in exam from Turner syndrome. So remember, most common is bicuspid aortic valve, but in MCQ they ask coarctation of aorta. Okay, different type of pulses based variants you will see where in AR, AS and HOCM. Pulses paradoxes you will see in a lot of conditions. So remember, the common cause is asthma. You will see in cardiac tamponade. You can see this in COPD. Pulses alternance you can see in any condition causing left ventricular failure. Water hammer pulse is called Corrigan pulse, we see in aortic regurgitation. Giant A waves or large A waves you will see in tricuspid stenosis, pulmonary stenosis or pulmonary artery hypertension and restrictive cardiomyopathy. Cannon A waves we see in ventricular tachycardia, junctional rhythm and complete heart block. No A wave in AF. And PATEX is a mnemonic, is understand this. You will see P for pericarditis. In case of pericarditis, you will see Y descent. In case of tamponade, you will see X descent. So predominant. So P means pericarditis, Y descent, tamponade, X descent. Okay, then understand these are the questions that they ask from murmurs. So if you see mid diastolic murmur, these are CARICOM, Austin Flint and murmur of MS. Early murmurs or early diastolic murmur, you will see Gram Steele, AR and PR murmur. Similarly, we have to remember some systolic murmurs. Hypertension, remember we have rule of halves as an MCQ that they ask in exam. Rule of halves, there is tracking phenomena. tracking phenomena. For hypertension, we have drugs like ABCD, ACE inhibitor, ARBs, A. Beta blocker are no longer considered first line unless patient is having angina or MI. C is CCB, D is diuretic. Refractory hypertension, we call it when it is not responding to 3 or more drugs that must include diuretics, especially thiazide containing diuretics. Group A, beta hemolytic streptococcus. Modified Jones criteria is used to make a diagnosis. Modified Jones criteria used to make diagnosis. You will see a new criteria is subclinical pericarditis. Subclinical pericarditis. This sometime you can see this is added in new Jones criteria. If I say, you will see fibrinoid necrosis. There will be fibrinoid necrosis and there will be vegetations. There will be vegetation. These vegetations are sterile along line of closure. Vegetation along line of closure, or we also call them commissural ends. Subacute bacterial endocarditis. So remember, the name of criteria is Duke's criteria. You will see this is like due to Streptococcus viridans. So this can form embolus. So when these embolus, they can migrate to different places. They can migrate to eyes. We call them Roth spot. They can rupture in your nail bed. We call them splinter hemorrhage. Splinter hemorrhage. There can be nodular enlargement in the palms and soles. We call them Osler nodes. Osler nodes or Janeway lesions. So understand these Roth spots, you can easily figure it out. These are seen in the eyes. Splinter hemorrhage you will see in the nail bed. These two are present in palms and soles. So how we make a differentiation between these two? So understand this. Osler nodes means O for oh my god. So you will shout with pain, oh my god, when we say when we have pain. So these are painful. J for just relax. When you are having these lesions, you are just relaxed means these are painless. So how we make a difference? Osler nodes are painless. Osler nodes are painful and general lesions are painless. Okay. Accentuated means loud S1, normal split S2 with loud P2 component. Diastolic murmur, opening synapse, straightening of left heart border, curly B lines, and prominence of left main pulmonary artery. These are MCQ suggestive of mitral stenosis. I am expecting a clinical case from these findings in your exam in this attempt. This is my prediction. Okay, if I say Takotsubo cardiomyopathy, also called as octopus jar heart. Octopus jar heart, it is due to more release of catecholamines. It is due to excessive release of catecholamines. So we also call this broken heart syndrome. Broken heart syndrome. So heart shape will become like a jar. So if you see the heart shape, it will become like a jar. We call this octopus jar heart. Okay, now see this. A pediatrics overlap with medicine and radiology question. You can see tetralogy of Fallet. So you will see the classical pattern. This is what we call this boot shape heart. So just look at, follow me. Second alphabet is O in TOF and boot. You can see this appearance. We call this egg on string. So how to remember this? Again, follow me. Second alphabet is G. Simple. Okay, you can see this is called figure of 8 appearance or snowman heart. Figure of 8 or snowman heart. So if I write 8 EIGHT and TAPVC, both 8 and TAPVC are having 6 alphabet. Epstein anomaly, you will see the heart shape. It look like a boxy. We call this boxy heart or box shape heart. So these are 4 questions that sometimes they ask repeatedly in exam. Myxoma. It is most common primary cardiac tumor. If I say most common cardiac tumor are metastasis, But if I add the word primary, it becomes myxoma. You will see there will be a sound, we call this tumor plop sound. Tumor plop sound in myxoma. Okay, then if I say generally they ask question on tachyarrhythmias, so we differentiate arrhythmias based on QRS. So just I am writing this classification for you. QRS means QRS can be a narrow. QRS can be narrow or it can be wide. So if I say there can be narrow QRS, narrow, or I can use the word narrow or normal. So whenever you see a clinical case on ECG of arrhythmia, focus on QRS. It can be narrow or it can be wide. So first try to understand this, wide or broad. QRS means QRS is due to ventricular depolarization. If QRS is wide, it means there is a problem in the ventricles, so it is a ventricle pathology. It is a ventricle pathology. In ECG you will see P wave. P wave is due to atrial depolarization, QRS is due to ventricular depolarization. If I say QRS is normal, it means ventricles are normal. It means here problem is above the ventricle. Above the ventricle means supraventricular. Supraventricular means above the ventricle. It can be a problem in the atrium. So what is my take home message is just look at the QRS. If it is normal or narrow, remember it's always an atrial disorder. Wide QRS, if you see, it is a ventricular problem. Okay, then after that what you need to see, you should focus on RR interval. You should focus on RR interval. If I say this RR interval is regular or RR interval is irregular. Same thing here. If you see RR interval is regular or RR interval is irregular. If I say RR interval is regular, we call this PSVT or SVT, paroxysmal supraventricular tachycardia. If RR interval is irregular, then you need to see two things. Either there is more than 3 type of P wave, more than 3 morphology of P wave. We call this MAT. MAT means multifocal atrial tachycardia. If you see no P wave, if you see P wave is missing or no P wave, then we call this atrial flutter or fibrillation. So flutter will have bigger waves, we call them sawtooth waves. Fibrillation will have little tiny waves, fibrillation. So understand this, if you see narrow QRS, your differential should be PSVT, MAT, atrial flutter and fibrillation. If I say you see a wide QRS, then you see there is a regular RR interval. This will be your VT. VT means ventricular tachycardia. If you see irregular RR interval, then you should focus on 2 important parameters. One is you should see there is more than 3 different type of QRS. When you see more than 3 different type of QRS, you will see we call this torsadis. If you see no QRS, so basically it is not QRS, means QRS is unidentifiable. You can't figure it out whether it is QRS or where is the QRS. Unidentifiable QRS, if you see QRS, then we call this ventricular fibrillation. Simple. So this classification is very simple. If you remember this, you can solve one question of arrhythmias, a clinical question or an ECG. Coarctation of aorta, PDA, memory shuffle, rupture sinus of valva, these are MCQs. These are MCQs suggestive of your continuous murmur. Continuous murmur, also called as machinery murmur. Continuous or machinery murmur. Small BP cuff, there will be false elevation of BP. Cardioprotective cholesterol is your HDL. The most preferred artery for your CIBG is right internal memory artery, followed by left, followed by saphenous vein. Calcium changes in ECG. So remember, calcium is always inversely proportional to QT interval. If you see hypocalcemia, QT will prolong. If you see hypercalcemia, QT will shorten. Dyspnea in upright position, relieved in supine position, we call this platypnea. Drowsy sign, you will press over femoral artery, there will be systolic and diastolic bruit. On putting subclavian vein catheter, patient develops sudden onset respiratory distress. So clear cut hint here given the question, subclavian vein catheter you are inserting, this is patient developing pneumothorax. Patient is developing pneumothorax. Pneumatocyst is due to Staph aureus, sometimes it can also be due to Streptococcus pneumoniae. Both question came in your exam, they are expected to come again. Best test for pulmonary embolism is pulmonary angiography. Lung mottling is seen with pneumoconiosis, so remember lung mottling is a feature of silicosis. Okay, then the most difficult and the dangerous topic that they ask in exam is electrolytes. So let's see once again. Hyponatremia, sodium values are less than 135, but they are considered significant when it is less than 125. Right? So if I say how we define this, when it is less than 135, in 125 it becomes dangerous. So patient will develop symptom when it is less than 125. If I say hyponatremia, we divide into three categories, that is hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. So understand this, there is low sodium. Why sodium is less? Sodium is less for a reason. Sodium is less for a reason because the patient is having repeated vomiting or diarrhea. So if I say the common cause is diarrhea and vomiting. Euvolemic means volume is normal. The common cause for this you should remember is SIADH. Hypervolemic means total body volume is more because entire water and sodium they are accumulating in some third space. Third space means these are due to edematous condition like ascites, anasarca, nephrotic syndrome. If I say how you will manage this, here you give normal saline or we can give 3% saline. This type of euvolemic hyponatremia, how we manage, this is managed by giving Vaptans and fluid restriction. If I say here there is more fluid in the body, more sodium is also more, but it is accumulating in some cavity. It is less in the plasma, so here you need to give diuretics. If I say opposite of this hypernatremia, we define this, it is more than 145, but patient will have dangerous symptom when it is more than 158. If I say the treatment of hypernatremia, we give dextrose. We can give 5% dextrose. Patient is diabetic, then we can give N by 2 or N by 4, half normal saline or quarter normal saline. Hypokalemia, how we manage? We manage by giving injection of KCl. Injection of KCl we give when patient is having ECG changes and values are less than 2.5 or both, or we can give oral syrup potchlor. Potchlor is available in oral form. Hypokalemia, the ECG you will see U waves. If I say hyperkalemia, how we manage? So we have many treatment recommendation and this is expected question in this attempt. Hyperkalemia, how we manage? So understand this, if I say the antidote is calcium gluconate. Calcium gluconate. If I say hyperkalemia, we can give calcium gluconate. This is an antidote or this will antagonize the potassium. Then we can give drugs like insulin or we can give drugs like albuterol. Albuterol, salbutamol, these kind. Albuterol is more preferred. If I say these drugs, they will send extra potassium which is in the blood, they will send them back to cells. So this is calcium gluconate, how it will act? We call this antagonism. It is potassium antagonist, and this insulin and albuterol, they will send potassium back to cells. We call this redistribution. If it's still not going, give patient diuretic. Diuretic will flush it out, that is, it will excrete it out. So how diuretic will work? By excretion. What else we can do? I can give K binders, potassium binders. Okay, potassium binders, remember two names, that is SPS, sodium polystyrene sulfonate. Sodium polystyrene sulfonate. This is one of the K binder that we use, a common K bind sodium polystyrene sulfonate. What else I can use? If I say everything fail, then I can recommend the patient dialysis. Right? What I can recommend is dialysis. So understand this. If I say hyperkalemia, how we manage? We manage by giving calcium gluconate. Right? We can give insulin albuterol infusion. We can give diuretics. We can give K binders. Like we can give sodium polystyrene sulfonate. And ultimately last option will be dialysis. If I say hypocalcemia, patient can develop a Trotsky sign, caropidal spasm, Chvostek sign. So how we manage? We manage this by giving calcium gluconate. The treatment will be calcium gluconate for hypocalcemia. If I say hypercalcemia, now there is more calcium. What to do? More calcium, there are different causes. Based on the causes, we treat this. Like we can give steroids. If it is due to some autoimmune condition, we can give bisphosphonates. We can give diuretics, especially loop diuretics. So generally they ask question on treatment of hyperkalemia. Okay, to conclude this topic, if I say anion gap can be normal, anion gap can be high, there can be high anion gap, there can be low anion gap. So just I want to tell few diseases where you will find this. If I say normal anion gap or high anion gap, so first let me say, if I say low anion gap, where you will see? Low anion gap you will see where? In lithium toxicity. In lithium toxicity you will see low anion gap. Low anion gap you will see in multiple myeloma. And low anion gap you will see where? You can see low anion gap where? In low albumin. Low albumin means hypoalbuminemia, means nephrotic syndrome. So you can see this L is there, L for lithium, multiple is having L, myeloma is L, low albumin is L, everything is L. If I say high anion gap, so let's see first question. If I say high anion gap, if I say hypochloremia, metabolic alkalosis. So let's see this. When you have vomiting, there is loss of HCl. H positive is moved, means alkalosis. Chloride is removed, means hypochloremia. Along with chloride, potassium will be gone. So this is seen in vomiting. This is something that we see in vomiting. Anion gap in starvation, that we'll discuss. How we'll discuss? We'll discuss anion gap in starvation. So understand this. If I say we have different type of anion gap, like normal anion gap, high anion gap and low anion gap. So first thing important is they ask question on this. All are causes of low anion gap except, all are causes of high anion gap except, all are causes of normal anion gap. So if I say normal anion gap, where you will see? So normal anion gap you will see in DRU, means diarrhea. So you can see this in diarrhea or vomiting. RTA is renal tubular acidosis and ureterosigmoidoscopy. If I say high anion gap, you will see in cult. Cult means ketoacidosis. U is uremia. L will be lactic acidosis and T will be toxin. So if I say starvation can produce lactic acid or sometimes ketone bodies as well, so that can also lead to high anion gap. So see, anion gap starvation will be high anion gap. So this is about the anion gap that they ask in MCQ. So lastly, if I end with the question, a 60-year-old diabetic and hypertensive patient found unconscious pulse rate is 120, BP is more, bilateral plantar extensors are next line of management. So understand this, whenever you see a sick patient, there's sudden loss of unconscious, patient is found unconscious, you will clear with 5 vitals like pulse rate, BP, pulse rate, blood pressure, SpO2, temperature and random blood sugar. So it's mentioned it is diabetic. So this patient can have hypoglycemia or patient can have hyperglycemia, coma. So both hypo and hyperglycemia can cause loss of consciousness. So first thing you should check for vitals, right? After then, once you see first these vitals should be clear, then we can order for CT scan. So remember, in this case, the next line of management, immediately BP reduction is not required because BP is not that high. Mannitol IV VK when there is signs of raised ICP. CT scan we can do, but first check blood sugar because hypoglycemia can cause loss of consciousness. Hyperglycemia can cause diabetic non-ketotic coma that will also have unconscious state. Okay, so just I tried to summarize everything. So from my side is I have tried to cover the topics which are high yield. So I'm expecting there will be 10 to 15 questions from this discussion. There may be less, there may be more, there may be less. So this is from my side. All the best for your exam. Just do watch this video before your exam. Best of luck. Goodbye. Take good care. Give your exam with the confidence. Bye-bye. Take care.